Welcome back, everybody. This is the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Across from me, we've got our usual co-host, Ray Pace, and we every time, right? We got to have the sarcastic back and forth. But yeah, we got Ray across from me here, and we got two special guests with us today. We've got Dr. Stephanie Gaines with us, and we've got Jennifer Moreland, who is a nurse. And you guys do something that should be very important to us in the EMS world, but I certainly think it's underappreciated, and certainly the knowledge base just isn't out there, and that is sexual assault nursing in these insane cases. And we really wanted today just kind of get from you what it is that you all do, and how EMS intervention is important, and what pieces of this we need to be paying attention to, rather than just another transport of a sexual assault, or more importantly, because you were kind of talking, we were talking off camera, it's broader than just sexual assault. We talk about domestic violence, and there's other pieces of this that we really need to be more aware of. So first of all, hey, thank you so much for coming on here, and welcome. And let's start with that. What is the SANE program? Whoever wants to take that to begin with.
Mm-hmm. Go ahead. Yeah. So UH has a SANE program, or a sexual assault program, and like you said, we take care of patients who have been sexually assaulted, and also patients who are victims of intimate partner violence. We've had a program for over 10 years, but more recently it's become an endowed program. We're in our third year of being an endowed program, and so we've really had a focus on expanding our services and getting a sexual assault response, and getting SANE nurses trained for all of our community hospitals. So that's what we've been busy doing, me and Jen, over the last couple of years, is really getting people trained up and getting a response out in our community hospitals.
And was this previously something that was mainly focused downtown, and now we're trying to spread it out to the periphery? I mean, we were talking offline that you were even down in Ashland as of recently, right?
Yes.
Because this isn't a this isn't just a big city problem, right?
Right.
Yeah, this is. I mean, where else where were you based out of? And
So we're all based out of Maine campus, but we have lead nurses that have the different regions. So we have a lead that has Tri-Point and Lake West, and then we have a lead that has St. John, Parma, Ashland, and Elyria, and then I have Geauga, Portage, Geneva, and Conneaut.
Oh, you got a pretty big swath.
Yeah.
And then we all cover main campus in Ahuja.
Oh, everybody crosses over to main campus.
Yeah.
Fantastic.
So on the SANE nursing, a lot of people think SANE as it's a psych role because of the word SANE. And then a lot of people think sexual assault nurse examiner, that it's just sexual assaults, but we do human trafficking cases and domestic violence cases. So there's a term that's kind of interchangeable. It's an FNE, a forensic nurse examiner.
Oh, okay.
Because we do we're delving a little bit into victims of crime as far as providing resources for them.
All right, so let's tease that out a little bit. So we got the doctor, we got the nurse here. What's everybody's particular role in this? So you clearly were carving out that there's a specialty there, and I want to hear about some of that training. And what's the doctor nurse role in this program, and how does that break down day to day and week to week? And
Well, for the physician role, I serve as the I'm an endowed director for the program, but the medical director for the SANE program. So, essentially making sure a quality assurance program, providing the education piece, the training piece.
Medical oversight,
medical oversight, bringing awareness, that type of thing.
And how many nurses are in work? I mean, a rough number under that. I mean, what's our?
It's the size of the whole team. Maybe.
What's the team look like? Yeah.
Yeah.
I mean,
so
10 people, 20, 100.
Well, we have SANE certified nurses, then we have our SANE trained nurses, which we've been training for the last year and a half. And I would say in total, we probably have about 32 that kind of fit up under that umbrella. Yeah, across the system.
So I think you're clearly making some differentiations there. Is you've got some different tiers of providers in that as well. It's not just nurse-doc kind of relationship, medical director to nursing. What's that breakdown with? Well, let's talk about what I'm assuming the nurse examiner or the forensic nurse examiner or the SANE nurse. Let's talk about what's the training look like for that, and then the other. Do I have that hierarchy right? Is then what was the term you used? That's
certification.
Okay, yeah. Let's talk about the SANE nurse examiner first.
So there is a 40-hour didactic that you have to be a registered nurse for 2 years.
Okay.
And then you do a 40-hour didactic that trains everything SANE. And then we do a full 2-day practicum at main campus that all the nurses take. And then they do about probably about 100 hours of clinical.
Oh, wow.
To do that, to be able to do their own cases. And they have to train to do speculum training as well. And then after that, we do continuing education.
Okay.
But that's the training.
Wow, that's
a lot.
Yeah.
And then the certification you have to have in 300 hours before you can sit. 300 hours of actual clinical hours before you can sit for the certification.
And then what's the breakdown? Who would be seen by a certified versus a nurse? How does that?
The SANE trained nurses do cases just like the certified.
Oh, okay. All right. So it's just an extension of
the practice.
Oh, okay. All right. Fair enough.
Okay.
And the clinical part of it is, doing cases on your own, seeing patients, getting trained in how to do the evidence collection, getting trained in how to do the pelvic exam, and intimate exams.
Sure.
So that's all part of the clinical practice of it.
And I imagine a ton of documentation.
Lots of documentation.
Only imagine a ton of documentation
and then working with probably other agencies, not only within UH, but then I would assume you're working with the different law enforcement agencies where this could have occurred. And then in the hospital, I would assume, social work, like you talked about domestic violence or trafficking, which kind of moves in LE and social work, I would assume, from our organization.
Yeah. Yes, we work with our community partners outside of the hospital for resources for victims and with law enforcement, and then even with prosecutors and defense attorneys as well. And that's part of our practicum, the 2-day practicum that we have.
Yes.
That is the ins and outs of community and hospital.
Okay.
And paperwork.
Yeah, lots of paperwork.
Always the paperwork, right?
Because you're most likely going to be brought into that court case. I would assume if it goes to trial,
unless the assailant pleads out.
Okay,
and they do that a lot.
Okay,
but also with that whole practicum is the actual kit, what the kit entails as far as every step of the collection, and then how to we submit the kit to the Ohio Attorney General.
Oh, okay. Oh.
So when we have to go on the computer and we go to the Ohio Attorney General website and we punch in the kits, we punch in what law enforcement agency picks up the kit.
Okay.
And then the survivor gets that kit number, so that way they can see not results of the kit per se, but they can see the actual process.
The chain of custody almost
exactly.
along with
That's exactly what it is.
Yes. Yeah, because in the late 90s they had all those cases in the cities, big cities, with thousands and thousands of kits that had been there for 10 years. This way they know that something's happening with what they provided.
I understand.
Is the current system in place a result of that big miss? And it was what a while.
Yeah.
I remember that being in the news locally here. So
right.
Why did you just wake up one day and say this is a thing for me, or what piqued your interest to drive you down this path in sexual assault nursing?
Mm-hmm. Well, for me, I grew up in Youngstown, Ohio, so I'm a local girl, and my dad is 30 years retired from Youngstown Police Department.
All right.
And so I kind of always grew up in that, world where,
Environment, sure.
Yeah. And so I've always kind of had an interest in like crime and law and, naturally getting into the healthcare sector, seeing how those two
Yeah,
merge.
you can blend those, right?
Yeah, so I thought, it was a perfect fit for me and something that I've always been interested in.
Oh, that's
And then my interest, I'm from a very rural area, and there were lots of assaults,
Sure.
lots of domestic violence. And as a child growing up, if you see it all the time, you don't see it as something that's not normal.
right. Yeah.
And the awareness was not what it is now. So then in my nursing, when I was doing critical care, there were many, many, many human trafficking cases and sexual assault cases that we would see that the person didn't report it. And then they get discharged and they leave. And then afterwards we learned all these things. So there were probably hundreds of people that were human trafficked
Right.
or domestic violence victims and survivors when they walk out of the hospital that didn't report it. And now with this training and with the constantly providing education to all the nurses, there's a new awareness.
Right. Well, I mean, we were talking off air, and of course, Dr. Hill's behind the camera again today. But just statistically alone, we've passed people through our EDs, had them in the back of our ambulances that we didn't pick up, that we didn't know. They fit in that category, and we simply didn't catch it. Right? It's impossible not.
And that's the thing too. It's like, being first responders and being on the front line, we are like one of the people that, are most often going to interact at some point in that patient's life or that victim's life. And so we have an opportunity there to be able to do something or, offer some help or offer some resources or, that might be that patient's only opportunity, to get out of that horrible situation.
Sure.
Yeah, so we talked about training and all the training that goes into becoming a SANE nurse. You kind of touched on the forensic nursing. Could you maybe just expand upon that, what that training looks like and maybe how long it is and things of that?
That's the didactic and the practicum and the clinical hours is that training. But the actual forensic part of the collection, so when someone comes in, the priority is medical first and safety.
Sure.
Then we look into the collection of evidence.
Okay.
And so for EMS crews coming into a scene that they know, you mentioned the evidence collection. Yeah. So the only evidence that person should be coming in the ambulance with into the hospital is what they actually had on or have on, because someone touching those clothes could tamper evidence.
Cross-contaminate,
Yeah, so it's best to, like, if the person, like, what were you wearing when you were assaulted? They tell you, and then they say it's at home. It's in my hamper. You notify police, and police will pick it up.
Let them handle it.
Yeah.
Yes.
Yeah, that way it's not... That way the chain of handling is very limited.
Yeah, it keeps the chain of custody just
it
clear,
keeps the evidence.
And clearly documented.
Correct.
Right?
Yes.
Yeah, it was
We're
obtained the correct
the
way.
wild card in this in this situation, right?
Yeah.
We kind of are, right?
Yeah.
Yeah.
But if the EMS crew, like, said, when they're are these the clothes you had on their assault, and they're like, no, they're in my hamper, the EMS crew could tell police or tell the hospital their clothes are in the hamper.
Yeah, this isn't
What they had on.
what they're wearing wasn't in place during, and the medical first, right? That was kind of what I needed to get out of this, for the audience's sake, is let's say that this isn't somebody who walks to the cot that is it is severe trauma type situation, right? Is even though we know that it's all of our standard resuscitation, all of our standard stabilization, all of that has to take precedence over essentially worrying about the whole patient first, right? And then sadly you have to pick up the pieces and sort that stuff out after the fact in your other role, right?
Right.
we were just talking about and it wasn't a DV or a sexual assault case. It was just a trauma case. We were talking earlier amongst ourselves about a case where there was a traumatic incident, and actually it was a DV case. Now that I say that out loud, it was a DV case. It was a traumatic incident, and the crew spent like the entirety of their time worrying about collecting evidence and bagging stuff up and this and that, and really did not formally or properly address the patient's wounds like they should have, right? So that whole medical first thing needs to be said, right? This is important, but it doesn't trump treatment. It doesn't trump,
any type of treatment that the patient
treatment
might need.
protocol. Yeah, save the whole first, right?
Right, definitely. I mean, I think, people it's easy to get interested in what happened and playing the detective role and trying to figure it all out. Our job is to treat the patient first and treat any injuries and things like that, stabilize the patient, of course. But, that's not our job. It's not our role to try to, suss out what happened, and try to play investigator.
Yeah, it's a fine line. Obviously, we need to treat our patient first, and evidence collection still needs to be running in the back of your mind. I don't want to destroy any evidence or do anything improper, mishandling or anything like that. But I think you bring up a good point, because a lot of times I think as EMS providers, when we get into that situation, kind of like we talked off camera and just when we first started, it's just, I don't want to say it's an uncomfortable feeling in our world. I don't want to I don't want that to come out wrong. It's just, I think in an EMS provider's head is, I don't want to do anything wrong, right? I want to try to treat my patient the best I possibly can, but I also want to preserve the evidence as best as I can. I don't want to do anything wrong that could hurt their case, for lack of a better word, or impede any of that. I just think, in my opinion, as a provider, for any of the patients that I've transported, that always kind of runs through my head. It's like I'm like tiptoeing around it, for a lack of a better word. Like, I think I would always assess them and assure they had any type of medical care they need 100%. But I think it's just everything up. It's like, well, I just want to wrap you up in a sheet and take you to the hospital, and I don't want, you know what I mean? And I don't want to I don't want that to come out wrong.
Right.
But it's just,
you're right.
I don't want to mess anything up with evidence and all that. I don't get down in the weeds with the story or playing detective. It's just, I don't want to destroy any evidence, for lack of a better word.
I think that's a very common fear that people have, especially when this is potentially a crime that has occurred, right? But, if I can encourage people to try to, not have that fear, because you really can't mess things up. Our job is to treat the patient, take care of the patient as best we can, and then, the evidence part of it kind of comes afterwards, and I just want to try to encourage people to not have that fear.
Yeah,
but a lot of people do.
And I think that's what this podcast is about, is to try to highlight something
Stuff like that.
Just to try to expand upon it. I mean, this is a specialty field that you're both involved in, and thankfully it's not something we maybe see as much, or maybe it's possibly something we overlook, just because we don't. There's other cues we could pick up on, if it's domestic violence or trafficking and things of that nature. So, we really appreciate you being here and giving us some of this knowledge to allow us to share with other providers so we can perform better in the field for that patient.
Yeah, definitely. Thank you for having us.
I think it's huge that we have this conversation. Right?
Yeah. And one thing I do want to say, too, as we're talking about, evidence collection, if if it was a sexual assault patient and they want to come to the hospital to see the SANE nurse and have evidence collected, just be mindful that we do collect their clothes as evidence. So if it is the clothes that they're wearing that they were assaulted in, we will send that off as evidence. And so maybe you could inform the patient. Yeah, grab some extra clothes. So you have something to go home in.
Send them home in some scrubs.
This is a very difficult time for them, or the most difficult time for them in their entire life, and then we take them to the hospital and we're going to give them a gown, right?
Yeah.
That's it, and that's not.
That's
a great point.
That's a simple point that
I wouldn't have thought of as a provider.
I wouldn't have, right? Yeah, is do I intuitively know that? Yeah, that has to go for. Yeah, I intuitively know that, but would I have put that together on scene and been like, hey, look, this is probably going to be evidence.
Right.
I would have thought, but that's a great, patient advocacy thing that you can do, right?
So speaking back to the apprehension of the evidence, the apprehension to like
Mess the scene up.
of all things evidence.
I can't think of a better way to say it. I'm sorry.
So part of our practicum, we have prosecutors come in and talk with the nurses because that's the biggest part of the whole like collection part. And every prosecutor has said, your evidence does not make or break a case. It doesn't make or break a case. So don't let that inhibit your care or change any of your methods of how you treat your patient. Like it doesn't make or break it.
You can't mess it up.
Right.
That's the bottom line.
Yeah. It doesn't
You
make or
can't
break a
mess it
case.
up.
It just augments the case that they're already
Right.
that they're already making.
And I think one of the things too to kind of piggyback on that, the more we talk about it, like at my department and my fire department, we have a great relationship with our police department. So our detectives, obviously you're going to have one of the regular shift officers will be there responding to that call, and then they call our detective bureau out. So they're going to be there to assist us with a lot of those things, and I think I'm sure it's the same way for many other fire departments that are listening to this. If you have a good relationship with your police department and having a good first name basis, like with our detectives, we work with them. They kind of take that mindset away from me, like, hey, this is what we're going to do. We work, it's a collaboration between us and them on the scene. Yes, we're taking care of the patient. They're more evidence driven. Right. They're going to follow the chain of custody. They're going to handle this part. And I think it's just good interoperability between, two different agencies will also help it be more successful. So maybe we should encourage fire departments to have that conversation with their police department
Ahead of time.
Hey, could we just talk about that? Maybe invite the detectives over or one of the officers over to kind of talk about, I don't want to say scene preservation, but like scene preservation, evidence collection, kind of their side of the house that they handle. And then we talk about how we're going to take care of the patient and, transport them to the hospital and take care of their medical needs as well.
Going back to our tactical medicine episode, right, where it was a very similar conversation. On scene is not the time to be figuring out who's doing what, right?
Yeah, yeah. I mean, we have that conversation a lot, like athletic training. When we talk to Dr. Flannery,
good point.
We meet up and we talk to the athletic trainer about, hey, if a player's injured on the field, this is a different type of scenario, but maybe we should encourage the fire departments to have more of a connection with their police department, have that conversation before you get onto the scene. And that'll probably add to more just comfortability from that standpoint, because they're going to worry about the evidence collection and stuff. To your point, it's, that's their wheelhouse. It's not ours. And they're going to want to collect the story or follow us to the hospital and then meet with, you as a physician and you as the patient's nurse and have that conversation. So maybe even just having more of an open dialogue with your police department would be beneficial to some of the EMS providers.
Yeah, or with you all, right? I imagine you have an outreach process for Prehospital or basically anything outside your walls, whether it's law enforcement or pre-hospital care, right? If they wanted more, or for you all to come out and do some cases or something with them, I imagine in that pool somebody would be willing to do that, right?
Yeah, definitely.
I can recall historically when I've had a couple of SANE nurses come out and give some presentations, and nothing quite this in depth, but really go through some cases, stuff that we should hit. But again, we just don't do it enough, and I don't. You were trepidatious about using the word uncomfortable, and I don't know that that's wrong, right?
Yeah,
so I mean, it doesn't mean you're incompetent or unable to care for. It's like, I don't do kids every day, right? My comfort level with kids is far less than super sick adults, which I'm great at, right?
Yes.
And that's my bread and butter work. Doesn't mean I can't do them, or So I actually think it's definitely a comfort level thing, right? You put me on this case today, had a few in my career, would it? No, I think it does come down to a comfort level. And armed with knowledge, we can get past that, right?
And we would gladly come out to wherever to speak in the community about all things SANE. about human trafficking, about domestic violence, about strangulation, which is a hot button right now.
Well, so talk a little bit about that, because you got going here again off camera while we were getting everything together, and that is a whole. We were looking at website over here, and just that subset of injury and whatnot. I mean, there's all kinds of information. What was the site you were telling us about for
the Strangulation Institute?
Yeah, Strangulation Institute. I mean, they're California-based or something, as I recall. But there was, and we're going to put that in the show notes so people can look at that.
Great.
There was all kinds of information in there, not just for your specialty, but as we just searched paramedic, I mean, it dumped all kinds of resources out in that. Strangulation aside, are there any other resources in this domestic violence or sexual assault space that we should be aware of on the pre-hospital side to reference, that we can put in there as well? Are there other institutes? Are there other organizations out there that would have?
Yeah, there's a lot, actually. So back to the Strangulation Institute. Sure. They're a stem of the Family Justice Center, which is out of San Diego, and they have a lot of resources on domestic violence as far as for healthcare providers, but also just community resources like the Rape Crisis Centers. They're wonderful resources.
And there's a Ohio protocol for EMS response for sexual assault.
Yeah.
So that's something relevant. Yeah,
that's what ours is modeled off of, right? It was cut and paste, basically. I mean, this is what it really was, right? So, what about the reporting? How we made reference to it. I think everybody intuitively knows. Do you have any idea of what the misses are? Right? How many of these patients get through that we never knew about, or we didn't know about them until it was too late, kind of situation? What is that? We know it's underreported, but how bad is it? Is really my question.
Statistically, only 3% report.
3%.
3%.
Wow.
Yeah.
And that is combination sexual assault, domestic violence. That's
and then
all comers there, or just one or the other.
It's
everything.
Yeah.
Oh wow.
Yeah.
That's
when you consider the statistics of the people that are actually assaulted, that's nothing.
Yes.
That's nothing. And then looking further into statistics, and I've only been doing this almost 2 years.
Sure.
It's crazy how the statistics are coming to fruition, and I'm seeing it.
Right.
I am physically seeing it. An example, domestic violence cases. Someone will be assaulted 7 horrific times on average before they leave.
Wow.
And it'll be at, different levels, and they'll probably receive different levels of care. Not that any of it's reported.
Yeah.
I mean, it's minimal on the reporting, but that's staggering, really. 7 times, 7 horrible assaults before they leave.
That kind of brings up a point. It was said in conversation, but let's just hammer that home. Is the patient has to want to participate in your exam, right? They have the
consent.
They have to consent. They have a right to refuse this, right?
Yeah.
So how often do you see that where it's clearly a case of, and they just don't want you to intervene? Is that
in terms of domestic violence?
Domestic violence or sexual assault, how often is it clearly fit the pattern, fit the profile, but they just don't want you to.
Yeah.
They don't want you to do the examinations. They don't want you to collect the evidence. They don't want you to do your piece.
Yeah. It's situational,
Sure.
Depending on people's situation.
Instinctually, we want to rescue everybody. You have to leave him, or you have to leave her. She or he, they're going to kill you.
Right.
And they stay.
Right.
And that's the most gut-wrenching, because they're going to die if they don't leave.
Right.
But it's up to them. And there's different reasons. There's financial reasons, or there's children. There's different reasons why they don't leave.
Yeah.